That's great. Thank you, everyone, for joining us today on this roundtable on neighbourhood health. My name is Lee Peart. I'm editor of Healthcare Management. We are a digital publication focused on supporting integrated healthcare. We are delighted to have such a prestigious panel to discuss today's topic. Our experts represent the full length and breadth of the country and cover the voluntary sector, NHS trusts and local government. I'd like to start by just asking you each to introduce yourselves individually and briefly describe your role in neighbourhood health. If we could start with you, Amajit.
Sure, yeah. My name is Amjit Chauhan, and I'm the Chief Executive at Helpforce. We provide and support volunteering in clinical settings. And I guess our role in neighbourhood health has been mainly around the work we're doing in Cornwall over the last few years. Cornwall is one of the 43 pilots that's run last year, and our work is to evaluate the impact of the Cornwall programme. And actually, we're delighted to announce that the last year, the evaluation has shown that programme has saved 11.6 million in avoided costs. So it really demonstrates the importance of neighbourhood health if applied properly, and of course working with the amazing PPL as well.
That's great. Thanks, Amajit. Lisa, would you like to go next?
Yeah, thank you, Lisa. My name is Lisa McNally. I'm the Director of Public Health for Worcestershire, as well as Honorary Professor at University of Birmingham. Obviously, as a DPH, I'm actively involved in the delivery of neighbourhood health at a local level across the county of Worcestershire. But I've also been working nationally. So, for example, with the Local Government Association, working on guidance to public health teams for how they can best support not just neighbourhood health, but also strategic commissioning across the NHS.
That's great. Thanks, Lisa. And Lindsay and Abby, could we go to you next?
Yes, hi, I'm Lindsay Wright. I'm the team manager for mental health services in Hartlepool, and that's Tees Escombe Weir Valley NHS Trust. I've been invited here just to talk about that community transformation that we've implemented in Hartlepool and that sort of work on the ground in terms of neighbourhood services.
And hello, I'm Abby Butterworth, so I'm the community modern matron that works across North Tees community mental health services within Tees Escombe Weir Valley's NHS Trust. Previous to that, I also worked in primary care mental health across Tees Valley within TUV as well. So part of my role is to look at kind of the clinical quality of what we are doing in terms of community transformation within our trusts, but also from working in primary care previously, I can really see how that runs through into secondary care mental health services. So it aligns really nicely with the work that Lindsay does.
Thanks. And you next, Claire?
Thanks very much, Lee. I'm delighted to be here. So my name is Claire Kennedy. I'm one of the two joint chief execs and co-founders at PPL. PPL is a social enterprise that works really closely with colleagues across the public and voluntary sector, and in particular around the shaping and development of neighbourhood health. So my role here is I've got a perspective of working on the ground with colleagues who are doing the really exciting work within communities, working also at place, regional and national level as one of the advisors on the NHIP programme. We recently published, we also work with colleagues in the voluntary sector very closely, as Amajit said earlier on. We've recently published some quite sort of wide-ranging research called Towards a Model Neighbourhood, which is really looking to tell the whole story about neighbourhood health and how the power of the impact that this way of working can have on transforming outcomes across a whole system and for a whole population. It's a real pleasure to be here. Thank you.
Thanks, Claire. Emma, could you go next?
Yes, no problem. I'm Emma Hart. I'm Deputy Head of Communications for Cornwall Partnership NHS Foundation Trust, and I'm working on several projects and initiatives for communications and engagement with other colleagues across the system in Cornwall for integrated neighbourhood health, particularly, as you may well know, Lee, the work that's been taking place on the Isles of Scilly has been a core project for me over the last 18 months, but I am here in my capacity for communications and engagement.
That's great, thanks, Emma. And lastly, you, Trifina.
Hello, my name's Trifina Doyle. Thanks, Lee. I'm a place director from Cornwall, and I cover the north and east of Cornwall. We segment Cornwall into 3 geographies. So I'm representing one of 3 place directors, and I'm representing the Cornwall and Isles of Scilly health and care system. And we have been rolling out a county-wide programme about neighbourhood health for a couple of years now. We are a Wave 1 NHIP site, and I believe we're the only whole system, whole kind of, the only NHIP site which is the whole county in terms of scope. So thank you very much. Lovely to be here.
That's great, everyone. Yeah, I look forward to hearing more about your individual projects, as well as obviously looking at the national picture in today's conversation. So I'd just like to begin with last month's Neighbourhood Health Framework. There's a lot of goals in there, and obviously guidance as well. Could I just start with your thoughts, Claire, on how achievable you think the goals within the framework are?
I think the real question around the goals is around the what and the how. So I think that the goals themselves, in many ways, I mean, we can sort of talk about them line by line, but in many ways you can come up with different ways of achieving those different goals. And I know that when I've spoken to colleagues across systems, there are many things in those goals where they can see almost ways they can achieve them through a variety of different routes. I think when we look at those ambitions in the context of the whole framework and the messaging of the whole framework, the really interesting question is how can those be achieved in a way which tells a wider story, and which is part of really thinking differently about how different parts of the system can relate to each other. So I hope that makes sense as a sort of starting point.
Yeah, that's great. Thanks, Claire. Anyone else like to come in on that? Yeah, Lisa.
Yeah. Wholly agree with Claire, what she just said. I think the devil will be in the implementation. Take guidance on a page, requirements on a page is one thing, but the reality of how that is translated into action is quite a different thing. There's a lot in there. I'm really inspired by the neighbourhood health vision. This is something which I think a lot of areas have been doing in some shape or form for a while, and it's nice to see it all consolidated and brought to life in a clear steer from government. I think what Claire said about bringing different bits of the system together is really important. I'm very keen, as you would expect as a director of public health, that we make sure we keep the neighbourhood in neighbourhood health, and that this doesn't become an NHS transformation programme. I think we'll have missed a trick if we don't broaden this out and look beyond the surgery doors, beyond the hospital doors, to how communities themselves, supported by local authorities, NHS colleagues, and of course, public health, can become the source of their own health improvement. So that's a big thing for me, I think.
That's great, Lisa. And could we have a comment from our NHS colleagues, maybe on your impressions of the framework, sort of initial thoughts?
Yeah, I was just going to echo what Lisa's just said there, in terms of that it needs to not be an NHS takeover, which was definitely the stance we had when we were asked to pilot the community transformation agenda initially, and really build them relationships with our other colleagues from, our partners, place-based. That was key for us to really embed and get ourselves kind of working together, which is what we've achieved. And I think that's where we stand out from a Hartlepool perspective. We have overcome them challenges and reduced them barriers so that we are working collectively. And I think that's the strength in kind of where we sit currently, in taking that neighbourhood services further into that, shift, that left shift, and moving into the 24/7. So I think, from our point of view, we are really motivated from Hartlepool perspective to be taking this into this next phase of working together with our partners. Probably lots of them would have liked to have sit on this call as well, actually, to be able to endorse what we're saying. So yeah, I think it's just, that's key, is for it to be a collective and certainly not just NHS.
And you can't kind of lose the power in relationships. I think that's absolutely key. And I think when Lindsay mentioned challenges and barriers, there were a lot of challenges, weren't there? And what we had to do, which was really difficult back 5 years ago when we started to really drive the work through community transformation, we really had to listen to feedback, and feedback from our, you know, local authority partners, feedback from our voluntary care sector partners and agencies. And it was quite negative feedback from the local community, because I think within NHS we put ourselves in a bubble, and I think what we need to do is make sure that we're working exclusively with our partners and agencies to make sure people are right at the centre of the care that they need, and make sure it is place-based. So we have worked a lot with partner agencies and really took that feedback on board. Recently we'd had a meeting with lots of our agencies attended by NHS England to really reflect on that time through the past 5 years. And I think there's been so much positive feedback, hasn't there? An acknowledgement of how we've really used that feedback to drive positive change. So yeah, I think the power in relationships just can't be it can't go unnoticed.
Thanks. I'll add to that. So I completely agree with the comments about we will miss a trick if we just focusing on neighbourhoods. Brilliant. Focusing just on neighbourhood health or just the health aspect, problematic. We've renamed our local approach neighbourhood health and wellbeing, and so we can emphasise the focus and the importance on looking at the wider determinants of health. So looking at housing, looking at education, looking at community transport, those types of really important issues that we know if we don't get right actually really impact on health outcomes. I think the importance about the devil in the detail is absolutely right, and I think the framework is really helpful, and yet we also just have to be very realistic about some of the constraints that we still face in terms of different regulatory approaches to different partners working in a neighbourhood, different estates, the challenges of moving capital from one part of the system to the other. So I think it's a great, gives us permission. I think the test will really come when we actually start to get to some real issues that we have to work through.
That's great. Amajit, would you like to give your thoughts?
Yeah, no, I think I was just adding into that. I mean, I think that the move between the NHS and local authority, and also pushing healthcare upstream, is going to be really important. We know it can work, and it does work, just from looking at the pilots that finished earlier this year. I think from our perspective is making sure that there is a voice for the voluntary sector. Voluntary sector organisations have been doing neighbourhood health for years, and doing it really well. And I think it's really important that we don't forget that, and make sure that communication and networking and partnership extends into applying that learning, and making sure that those organisations are also funded in part of the process, because they're very small. There's some of them only 2 or 3 people, and run by volunteers and managed by volunteers. So we don't want to forget their expertise, and also make sure that they have a seat at the table.
That's great, Amajit. It might be a good point here to talk a little bit in detail about the programs you're already involved in here.
Well, I mean, from our perspective, we're currently involved with the initiative in Cornwall. As I've said, we've done about a year-long evaluation, which has shown the impact of that programme. £11.6 million saved in avoided costs, which is huge. I mean, if you apply that across England, the savings amount to close to £1 billion. So I think what we're saying is that if done well, with shared responsibility, with involvement of the voluntary sector, neighbourhood health can make a difference. And we're currently doing some work with Claire and her colleagues at PPL, again, at looking how we can apply that learning to make sure that everybody has a seat at the table.
That's great. Would you like to say any more, Claire, about your work with Amajit?
Well, I mean, that specific piece of work is really looking at what's the infrastructure that exists, if you like, as a core part of the system, but what we might traditionally not have necessarily thought of as the system, because the system tends to end up being defined as the kind of statutory bodies and the big organisations, but really understanding what are the behaviours that are required on all sides to be able to facilitate really effective joined up working. So, I mean, a lot of our approach is about really recognising what each organisation is bringing to the table, which is unique, and often it's quite difficult for each organisation to necessarily understand each other from the start. So you have to have the time to really understand what are you bringing, and therefore what do you need from colleagues around the table to be able to perform really successfully. And as Amajit was saying there's things around multi-year funding for voluntary sector organisations. There's also just a recognition of the different resource models and the different workforce models that exist across different organisations, which all have different pros and cons. You know, it's not necessarily that one is better or worse than the other, but they are just different. And in that difference, I think what we actually find are some solutions to some complex problems, because there is flexibility that exists within the VCSFE sector that doesn't necessarily always exist within statutory partners. And there is some consistency that can come from statutory partners, which can be used to support colleagues in the VCSFE at times where they might need that as well. So a lot of the approach, as Amajit would confirm, is around really agreeing what's the shared challenge, what does this particular population need, and then almost there's a sort of Avengers Assemble approach, like how if we all come together, what do we all need to do to be able to meet that challenge and to address that particular to achieve that particular outcome along with that population. And that was the final thing I would say, is that I do genuinely believe that when we're thinking about neighbourhood health, we're thinking about a completely different set of relationships, also involving all of us as citizens. It's a much more co-creative process. It's far more around a genuinely asset-based approach and perspective. From a citizen perspective, meeting us where we are. So each of us will have different things that we bring to the table, different things that we need, and things that we can't do, and that we do need support to be able to achieve. And I think being part of that process is also around creating agency within the wider population, which is a key thing of achieving a completely different set of relationships.
Tryphena, would you like to say a little bit about how you're working with, in terms of partnership, working with the voluntary sector?
Yes, so one of our first principles, we have in Cornwall put a sort of a neighbourhood health enabling fund to support the implementation of neighbourhood health, recognising that it's very easy to talk about left shift, and at the same time sometimes we just need to have a bit of double running or some funding to test things before we scale and spread. So one of our principles around that investment is think voluntary sector first. So we are encouraging everybody, whenever you have an idea, make sure you are talking with your voluntary sector partners. First of all, find out what they're already doing in this space. And it turns out, yes, the voluntary sector will put their hand up and say, no, probably we're not the people to be doing knee surgery. However, if you want to be talking about tackling loneliness or putting together community hubs, you know, we've got all of that. So we've had lots of investment going into the voluntary sector. We've got a network of community hubs. We've got investment going into a fantastic community health and wellbeing worker initiative. So I think that the sort of takeaway really has to be that unless you set the commitment to really kind of put voluntary sector on a sort of an equal pegging, you know, you're really not going to get as far as you could or as fast as you could. And that comes down to even little things like when we list out the partners in our in our neighbourhood teams, this may be common to other people, but, you know, we'd sort of say GPs, community trust, and the voluntary sector. So we just do little things like flip it, put the voluntary sector at the top.
That's great. And I think up in Hartlepool there, Lindsay, Nabby, you're coming up with some innovative ways of working, bringing different services together under the neighbourhood health model. Is that right?
Yeah, that's correct. I think we've established for a long time now a steering and delivery group, which involves every one of our partners, and it's led by the VCSE. So they take that active role in pulling them meetings together. So we've had them embedded for a good while now. And what we do is come together to talk about next developments. And obviously the neighbourhood health is the stuff that we're talking about currently. And it's very much driven. It's not a TÜV takeover, it's not an NHS takeover, it's very much kind of driven by our partners, particularly the voluntary care sector. So that's been amazing, and that continues to thrive, and that's where we've built them relationships. And by changing our language and like what we've spoke about, but we've also then off the back of that establish some exclusive partnerships, so they come to us and identify where we can see the needs for our local population, where we can't provide something. They've come in and suggested things, and we've established some really good joint partnership working to actually make that offer stronger to our local population, and that continues to develop. So we've done some, you know, some excellent work and got some really good outcomes.
That's great. And Lisa, could I let you come in here in terms of how you see local government's role within the neighbourhood health partnership? I guess what that role should be.
Well, I loved what colleagues on the call said about that, almost like parity of esteem between, you know, the NHS work and voluntary sector and other maybe less medical stakeholders, including local authorities. And I think what you're doing there is laying down the challenge to the whole NHS. We think about, for example, how are those leading neighbourhood health in the NHS relating to their health and wellbeing board? Are you seeing the members around the table at the health and wellbeing board, including councillors, voluntary sector, social care, public health? Are you seeing those as integral partners who can help you deliver on things like the issues colleagues have mentioned, like loneliness, digital inclusion, community development? By the way, those things, let's not see them as side issues. Those are integral to health improvement in communities. And there may be some areas around the country, is the Health and Wellbeing Board a box to tick off? Is it a meeting where you take your NHS neighbourhood health update to and survive the meeting? And I think there's a role there to play for health and wellbeing boards as well in that. And that's about achieving role clarity. You know, it's probably not the best use of health and wellbeing boards' time to second guess in detail what NHS colleagues are doing about how their services are connected and resource allocation. But health and wellbeing boards can do a lot that supports health in communities, reduces non-elective admissions, helps to shift care into the community. So I guess what I'm saying is, let's have everyone play to their strengths. Let's have the voluntary sector do what they're really good at, engaging and developing communities. Let's have the NHS do what they're good at, and equally public health. We've outlined a 3-dimensional approach to public health support, which is all about data analytics support, risk stratification, etc. There is support on health improvement and community development. And that's the key here. If we all play to our strengths and give each of those strengths parity of esteem, we can become more than the sum of the parts and do something genuinely transformational as systems.
That's great. Thanks, Lisa. And unfortunately, we don't have any GPs in this session, but the health, the framework talks very much about the GPs being central to the actual delivery of neighbourhood health services. Is that something that everyone would obviously agree with?
Yeah, 100%. The relationship between the GP and the local population is absolutely at the heart of this. And I think when we're thinking about neighbourhoods, it's we talk about them in this context as sort of like policy ideas, but they're actually where people live, and people's local GP is a key part of where they live in the same way as their local school would be, etc., etc. And it's a very personal relationship. I would absolutely see it as being at the heart of this.
I would agree with that, Claire. And just an example from Worcestershire, what neighbourhood health has done for us is unlock a new depth of relationship with primary care networks and primary care. We have, of course, always worked with primary care, but now what we're doing is having regular meetings with primary care leaders, supporting them to deliver on neighbourhood health and allowing them to focus on what happens in the surgery, while we focus on the community and the health improvement outside of the surgery, which can provide a receptive foundation for moving more care into the community. So I think, you know, I would urge all my oppose in public health around the country is to take this opportunity of neighbourhood health to really deepen your relationship with primary care networks and primary care, who, as Claire rightly said, are going to be central to all this.
And I would probably be able to echo that. I think in Teesside, our relationships with our primary care networks, our GPs, our primary care colleagues have really, really improved. We implemented the ARS, so the Additional Roles Reimbursement Scheme, and mental health roles back in 2021 now. And then in each primary care network within Tees Valley, we have a mental health practitioner. We've been able to expand that now and have SMI, physical health leads, mental health and wellbeing practitioners, other various mental health roles, to really get almost a team within a team, which is absolutely what we want within neighbourhoods. But I think with that, whilst it's strengthened our primary and secondary interface in terms of relationships, referrals, those clinical discussions that may have just been an open door, shut door referral, we're having really live conversations that's really helping. But at the heart of that, it's been our GPs as well. So referrals have improved from GPs because we weren't seeing great referrals, very limited information, maybe through lack of knowledge or just the high acuity that we see within primary care. But also I think being moved to different places. So I know our Hartlepool team, our mental health service within the community is now embedded within the GP surgery. So we've got a centre where there's 3 GP surgeries now, community mental health services embedded within that. That's been absolutely astronomical, hasn't it, for our relationships, and it's just really, really improved. But we've seen that mirrored across Teesside as well as just Hartlepool as well.
That's great. Anyone else would like to just say a little bit about primary care at this point? Or?
Yeah, thanks. So I agree, primary care absolutely essential, and the building block around, we talk about kind of the locus, the sort of like the centre of a neighbourhood. And also I think it's important to recognise when we talk about concepts like left shift and moving from hospital to community, I think there's also something that we need to be thinking about. What can we move out of primary care into other areas? What could be picked up by the voluntary sector? What doesn't even need? So I think the statistic is 1 in 4 GP presentations are for non-medical reasons. So what can we be doing at a neighbourhood level? Yeah. I think one of the most important things, as well as being that sort of entry point into the system for many people, is GPs have the lists. They have the lists of people who are being supported in that neighbourhood. And something magical happens when you start looking at lists of people as a neighbourhood. So we were talking in Cornwall this week about vaccination rates. Now, vaccination is an issue that traditionally has fallen onto the shoulders of general practice. General practice is kind of held to account about under 5 immunisation rates. But what's really interesting is when you start to say, is this a general practice issue or is this a neighbourhood issue? Because as soon as you reframe it as a neighbourhood issue and you get the list of people who haven't been vaccinated, you can start to have some very powerful and exciting conversations about who else is supporting this person, who else could be raising awareness, how else could we be reaching those people. So I think they're an essential part of that broader multi-agency team within the neighbourhood.
I think what a fantastic point. And we learned, or at least if we didn't learn during COVID, then we never will, how important neighbourhoods and communities are to the uptake of things like vaccination. And, so why would we see an issue like that as solely a responsibility of general practice? So in Worcestershire, we've been pushing hard on our MMR uptake, and we've worked with the community to set up pop-up clinics in the heart of neighbourhoods, sponsored by local community organisations in the sense that they promote them, and it's sent our vaccination coverage rates up. So completely agree with that. We can't leave bits of this to one bit of the system. And apart from anything else, if we do, we will overwhelm those bits of the system. If there were GPs on the call today, they probably will have mentioned that it's fragile. It's never far away from being broken in terms of being overwhelmed by demand, as are many other services. So the more we follow that advice and don't leave one bit of the work to one bit of the system and become more than the sum of the parts, we will thrive.
That's great, thanks. I just wanted to pick up on something someone said earlier about addressing the wider determinants of health. Would you like to expand on that in terms of how neighbourhood health teams can do this by working together? Anyone on that?
Well, sorry, do you want to go first, Claire? Go ahead, because after I've spoken, go ahead.
All I was going to say was I think that one of the real opportunities that I think we have is that because we've got greater access to data and insight and in that sense much deeper understanding of our population, I think we have the opportunity to have different kinds of conversations about how we want to help people and to support through the wider determinants. So, you know, we know that in the commercial world, like Amazon probably knows more about us than most of our friends do. I'm not suggesting that that's what we want to aim for, but that the ability to really understand what's happening in someone's life without them, without necessarily having to wait for it to present, if you like, it is a real shift. And I think it creates a whole different set of opportunities in terms of how we respond. And I think we've talked a lot on this call about the value of teams, so a team-based approach. And I think the thing about wider determinants is that it's a term that covers a whole range of things. And often those wider determinants are very unique to individuals, and they're specific sets of circumstances which will be difficult for some individuals due to a whole set of other issues that are in their own personal journey that existed far before we would ever necessarily have talked about them in this context, but which might be completely unmanageable to somebody else. So actually really understanding where that person's coming from and therefore what support they require is a very nuanced process. So having the data and insight to be able to support that process, I think, is a huge opportunity. I think we're only really just starting to get our heads around what that might look like in future and what opportunities that creates.
Yeah, I was going to come on to the importance of digital and data sharing. Does anyone else like to just give any examples of how they're using that?
Well, I think one example is exactly what Claire's just been talking about, how we need to move in our data. We know, don't we, that 80% of health outcomes are not determined by clinical care factors. They're determined by the social and wider determinants of health. The things that the voluntary sector can influence, the things that local authorities can influence. Loneliness and social isolation alone accounts in research for an enormous amount of variance in health outcomes, service demand use, right through to mortality. But when was the last time you saw loneliness or social isolation in a risk stratification model? It just gets elbowed out in terms of blood pressure, HbA1c, and you know, it's clinical models. So what we're doing, we're trying to build clinical risk stratification models that can only hope to account for 20% of health outcomes until we start sharing and incorporating data on employment, isolation, loneliness, poverty. Then we're not going to be able to do population health management properly. So I think there's a big data sharing and data population health management challenge for us all in the light of neighbourhood health.
That's great. Thanks, Lisa. Time's advancing. I'm aware of that. So I just wanted to maybe just wrap up by asking each of you individually for your thoughts. It's all been a very optimistic conversation, which is great. I just wanted to get your thoughts on why you think neighbourhood health will succeed this time when it hasn't done in the past. Maybe we can start with you, Amajit.
Yeah, look, I think this time round there seems to be more motivation around. There seems to be more dialogue. There's more openness, and also an understanding that we can't continue to provide a healthcare service in the way that we have in the past. I mean, our acute settings, you know, are swamped with patients, and that can't continue. We've got to find an alternative way to support and provide that healthcare service in the community. And as I said, I think that what I'm hearing more and seeing more is that there is more of an appetite for that to happen.
That's great. Thanks, Amajit. Lisa, could we go to you next?
You have to be optimistic, don't you? It's the only way I get through the day, to be honest. And I am. You know, Amajit made a really good point about us not being able to continue in the way we are. But you know, the technical challenges in neighbourhood health, data sharing, left shift, etc., are minimal compared to the challenges of shifting mindsets and how we view health. And I've loved being on this call today, listening to such a positive attitude from NHS colleagues, as well as other sectors, about seeing that one health approach, that whole community, wider determinants of health approach. So if we can keep that mindset in place and not revert back into comfort zones of just clinical services, just NHS transformation, then we've got every chance of doing something special nationally on this.
Thanks, Lisa. I could go to you, Lindsay and Abby.
I was just going to say that I think from a Hartlepool point of view, you know, we've got the building blocks that we've established through community transformation has made me feel more optimistic that we are in a better position to drive it forward. And I think that I'm very fortunate to work in a place where everybody's really, really passionate about being able to, you know, meet the needs of everybody in our local population. And I think the fact that we are all working together as one has been the change, and that people, we're talking very passionately about how we can achieve neighbourhood services and what that needs to look like collectively. So it's not just one person driving it. And I think that's been the key. So I think for us, I would speak on behalf of Hartlepool from a voluntary care and statutory organisation point of view that we all probably think the same. Yeah, we're not going to always get it right, and it's going to be a long, you know, a difficult process to get us to where we need to be. But I think the passion, the enthusiasm and the working together is there to drive it.
Absolutely.
Thanks, Claire. Can we go to you as well?
Yeah, just to add to what colleagues have said, I obviously completely agree. And I think that one of the things that really strikes me is that we're sort of at the end of the original kind of settlement for how all of this was meant to fit together. And I think that's, we can all sort of feel that and understand that. I think we saw in moments like COVID, the beginnings of what the new, if you like, settlement would look like. And I think that because of that, there's a real sense of possibility, and also a sense that people kind of have some of the tools to start to do this and to start to work differently. I think the flip side, that's the positive view, I guess. The flip side, I guess, is that the current model is not working and it's clearly no longer fit for purpose. So, I mean, I've been doing this kind of work for about 20 years, and the conversations that we have now are a world away from the conversations we would have been having 20 years ago, where almost the kind of the overriding thing was, well, we can probably just kind of inch our way through if we keep doing a variation on what we're doing now. I don't think anybody thinks that now. And I remember being in a meeting about a year ago with the hospital coup, who basically said, like, I don't have a plan B, like my hospital is full, I don't have anywhere else to put anybody, I've got no space for any more wards. So thinking differently about how we respond to the health and care needs of our society feels like a pressing priority now, and one that we're all agreed on. So we might be working our way through the how, but I genuinely believe we're no longer disagreeing about the what. I think everyone understands that we're going to do this.
Great, thanks, Claire. And yeah, get a quick view from Cornwall. I think you are on mute, Tryphena.
Thank you. So I think maybe start by looking at why it hasn't worked in the past. You know, why has it taken so long? And I think we could argue, well, it's been optional, it's been localized, being done on a pilot basis, it's been exceptional. And I think the difference now is that it is the core operating model, isn't it? We are talking about neighbourhoods being the organising units of delivery, and the pressure is unavoidable. You know, we have that kind of, you know, we have no plan B, we have the burning platform. And I think we've got the policy, we've got the relationships, we've got the structures, and we've got the permission now to work differently. And I think what's going to be absolutely key, and I think we are seeing it, is that sort of public acceptance of the shift and the importance of prevention, and moving away from hospital-centric models. So I think that's why we have such a positive place, why we find ourselves in such a positive place today.
Well, that's great. Thank you all for your time today. I can sense the positive energy in the room. So I guess the messages keep pushing forward, and we look forward to carrying on with the conversation to find out about your progress. And thank you again for sharing your time, and look forward to meeting again.
Thank you.
Thank
Pleasure.
you.
Thank you all.
Everyone.
Bye.
Thank you.